Hello everyone, welcome to Mediverse Atlas. In today's video, we'll be talking about megaloblastic anemia. Now, let us try to understand what exactly this megaloblastic anemia is. First, we'll be looking at the definition of megaloblastic anemia. So, megaloblastic anemia is a type of macrocytic anemia characterized by the presence of abnormally large, immature, nucleated red blood cell precursors due to defective DNA synthesis caused by vitamin B12 or folic acid deficiency. Now, what does this exactly mean? First, it is a type of macrocytic anemia. What is meant by macrocytic? The size of the RBC will be increased. So MCV will be increased in the megaloblastic anemia. If MCV is increased, size of the RBC is increased. So it is a type of macrocytic anemia. It is characterized by abnormally large, immature, nucleated red blood cell precursors. So what exactly happens in this megaloblastic anemia is, we all know that we require iron for the synthesis of hemoglobin. Similarly, for the synthesis of DNA, we require vitamin B12 and folic acid. So when this vitamin B12 and folic acid are not available, there will be defective synthesis or no synthesis of this DNA. If there is no synthesis of this DNA, the cell division do not take place properly. So if the cell division do not take place, immature RBCs are formed. So it is caused by vitamin B12 or folic acid deficiency. I hope you are clear with this. Now, looking at the types of this megaloblastic anemia, we have two types of megaloblastic anemia. The first one, it is due to the deficiency of vitamin B12. And the second one, it is due to the deficiency of folic acid. Okay. First, we'll be looking at the general common features of both the deficiencies, both folic acid and vitamin B12 deficiencies. So, the general feature include weakness, pallor, fatigue, mild jaundice, loss of appetite and weight loss. Now, what does this mild jaundice mean? This mild jaundice occurs due to hemolysis, that is due to the destruction of RBCs. It is due to the destruction of RBCs. So if the jaundice which is occurred due to the destruction of RBCs, it is called as hemolytic jaundice. Hemolytic jaundice. Due to this hemolytic jaundice, the person looks pale yellow in color. So due to hemolytic jaundice, due to mild hemolytic jaundice, the patient may look pale yellow in megaloblastic anemia. Now, what are the oral and GI changes? Glossitis and stomatitis. Now, what are the hematological findings? We have all seen that the MCV will be increased and large and immature RBCs are seen. Now, we have known that there are two types. One is due to the deficiency of vitamin B12, and the second one, it is due to the deficiency of folic acid. First, we'll be talking about the deficiency of vitamin B12. So megaloblastic anemia due to deficiency of B12. So what are the causes? What are the exact causes? The first cause, it is due to the inadequate dietary intake. When this inadequate dietary intake is seen, so it is seen in strict vegetarians. Normally, vitamin B12 is only available in the meat. The people who consume meat, there is no chance of deficiency of vitamin B12, because vitamin B12 is only available in the meat sources. It is not available in the plant sources properly. So the megaloblastic anemia, which is caused due to the deficiency of vitamin B12, can be manifested in the strict vegetarians and breastfed infants. What does this mean? Breastfed infants. If the child is fed with only breast milk for a chronic time, for a long time, there will be no inadequate supply of vitamin B12. So megaloblastic anemia can be seen. Next, the second one, it is due to the malabsorption. No proper absorption of vitamin B12 from the intestine. Normally, vitamin B12 is absorbed from the small intestine. Okay, so what are the other causes of this small absorption? The first one is the pernicious anemia, which is very important. We'll discuss this pernicious anemia in detail. The second one is the gastrectomy. The third one is the ileal diseases, and the fourth one is the fish tapeworm infestation. So in these cases, megaloblastic anemia is seen due to malabsorption. First, we'll be talking about pernicious anemia, which is very important. This pernicious anemia is also called as Addison's anemia. Now, what is the etiology? We all know that stomach has parietal cells. These parietal cells are present in the gastric mucosa. So these parietal cells help in the secretion of intrinsic factor of Castle. This intrinsic factor, which is released by parietal cells, this intrinsic factor, this help in the absorption of vitamin B12. So this intrinsic factor helps in the absorption of vitamin B12. So what happens in pernicious anemia is there will be failure of intrinsic factor secretion due to autoimmune destruction of gastric parietal cell. So if there are antibodies formed against the parietal cell, so these antibodies goes and destroy the parietal cell. So if the parietal cells are destroyed, there will be no release of this intrinsic factor. If there is no release of intrinsic factor, there will be no absorption of vitamin B12. Okay, so there will be megaloblastic anemia. First, it is due to the autoimmune mechanism, which is the main cause. The body's immune system forms antibodies against, first is the parietal cell. Antibodies which destroy the parietal cells to produce intrinsic factor. And the second type or the second category is the antibodies are formed towards the intrinsic factor. So there are two cases here. Antibodies are formed either on parietal cell or either on intrinsic factor. So if the antibodies are formed against the parietal cell, intrinsic factor is not released and vitamin B12 is not absorbed. So if the antibodies are formed against intrinsic factor, even vitamin B12 cannot bind to intrinsic factor and get absorbed. So in both cases, if antibodies are formed against either intrinsic factor or either parietal cell, there will be no absorption of vitamin B12. Okay, the second is the gastric mucosal atrophy. Long-standing autoimmune gastritis leads to atrophy of gastric glands. So if gastric glands leads to atrophy, along with the other glands, even parietal cells also get destroyed. If parietal cells are destroyed, there will be no release of intrinsic factor, leading to the malabsorption of vitamin B12 and other associated conditions. So if there are other autoimmune disorders like Hashimoto's thyroiditis or Addison's disease or type 1 diabetes mellitus, so there is a chance of megaloblastic anemia seen in those patients also. Now we look at the specific features of megaloblastic anemia. So what are the clinical features of megaloblastic anemia? Looking at the clinical features is very important to solve the case-based equations or the clinical-based equations. Now, first, neurological symptoms. The neurological symptoms are manifested only in megaloblastic anemia. So if you see the neurological symptoms in the question, go blindly for the megaloblastic anemia due to vitamin B12. Due to vitamin B12 deficiency. Okay, we'll look at the clinical features. So neurological symptoms are paresthesia. Now what is this paresthesia? It is the tingling and numbness in hands and feet. Next, there will be loss of vibration and position sense. The third one is the ataxia and spasticity. And this ataxia and spasticity is seen due to degeneration of posterior and lateral columns. We'll be talking in detail about the posterior and lateral columns in neurophysiology. Okay, so the neurological manifestations are paresthesia, loss of vibration and position sense, and ataxia. Next, what are the psychiatric changes seen in megaloblastic anemia due to vitamin B12 deficiency? The psychiatric changes are irritability, depression, memory loss. Now, what are the oral and gastrointestinal changes? Red sore tongue, that is glossitis, and loss of appetite and gastric atrophy is seen. Now, here there is a small note which is very important. So, RBCs are larger, immature with almost normal or slightly low hemoglobin levels, in megaloblastic anemia caused due to B12 deficiency. So synthesis of hemoglobin is almost normal. It is the most important point to remember. Synthesis of hemoglobin is not affected in this type of anemia. Only the size of RBC is increased. See, the synthesis of hemoglobin is almost normal in this type of anemia. So morphology of RBCs are macrocytic normochromic or sometimes hypochromic. So the most reliable option should be macrocytic normochromic only, because megaloblastic is anemia is related to DNA synthesis and vitamin B12, but hemoglobin is related to iron, right? So the color of RBCs remains same, whereas the size of RBC increases. That's it. Now, what are the specific tests prescribed in this confirmatory test prescribed to diagnose the megaloblastic anemia are antiparietal cell and anti-intrinsic factor antibodies. So these tests will be done in the laboratory to confirm the megaloblastic anemia. If the test becomes positive, there is a chance of megaloblastic anemia, and there are low levels of vitamin B12 in body. Okay, so these are the clinical features of the megaloblastic anemia caused due to vitamin B12 deficiency. And talking about the treatment, so when we talk about the treatment, we give vitamin B12 injections. We give vitamin B12 injections intramuscularly. So IM intramuscular vitamin B12 injections are given for the patients suffering with megaloblastic anemia due to vitamin B12 deficiency. Okay, now let us talk about the megaloblastic anemia caused due to the deficiency of folic acid. Okay, now what are the causes? Poor dietary intake and this folic acid deficiency, megaloblastic anemia of folic acid deficiency is commonly seen in alcoholics. Remember, if the patient history if the patient is a chronic alcoholic and came with the symptoms of anemia, there is a chance of megaloblastic anemia due to folic acid deficiency. Okay, so it is commonly seen in alcoholics, elderly, and malnutrition patients. And if there is increased requirement as such in pregnancy and due to malabsorption, or either it may also be due to drug induced cause also is one of the reason. So there are some drugs like methotrexate, phenytoin, and trimethoprim. This methotrexate is used in anti-cancer treatment, and this phenytoin is used as anti-epileptic. Okay, next. Now, what are the clinical features of this folic acid deficiency anemia, that is megaloblastic anemia due to folic acid deficiency? So the main feature here is that there are no neurological symptoms. So this is the main point to differentiate between the megaloblastic anemia due to vitamin B12 deficiency and due to folic acid deficiency. In vitamin B12 deficiency, there are neurological symptoms. Right? Whereas in this type of anemia, in folic acid deficiency, we do not have neurological symptoms. Similar hematological mucosal changes seen in megaloblastic anemia, glossitis, pallor, and mild jaundice we have discussed earlier. And here, low serum folate levels and normal B12 levels. So when we look at this serum analysis, the folate levels will be decreased and there will be normal B12 levels. And here, FIGLU test, you'll be discussing or you'll be learning about this FIGLU more in biochemistry. Okay, so this FIGLU test is increased after histidine load test. Don't worry more about this point, you'll be learning it in biochem. Okay, but just remember, FIGLU is increased after histidine load test. Okay, now we'll be just looking at this peripheral smear of the normal RBC and the megaloblastic RBC. See, this is the normal RBC. This is the peripheral smear of a normal person, whereas this is the peripheral smear of a megaloblastic anemia patient. You can see the changes. Here, the size of RBC is normal here as compared to this. See, here the size of RBC is more increased. So in peripheral smear, we'll be looking at the picture like this. This is the normal. You can see the RBCs are normal in size and normal in color. And here you can see that the RBCs are large in size and they are normal in color. No, they are not hypochromic, they are normochromic. So megaloblastic anemia is macrocytic normochromic. Sometimes it's hypochromic. That's it. Okay, I hope you understood the session. If you have any doubts, please do comment, and let's meet in the next video. In the next video, we'll be discussing the clinical cases related to anemia. Thank you. Have a nice day.